Thank you, and thanks for the attendees who are joining us in this conference. So today I'm going to present a paper titled Breast Cancer Patients in Syria, Quality of Life and Prognosis, which goes along very well to our goal. As it is known, October is Breast Cancer Awareness Month. Actually, 2020 has been a powerful reminder that we are all in this together, and our choices and actions have the power to protect the most vulnerable among us in a big way. The same holds true when it comes to breast cancer. Breast cancer is one of the most important health problems. Why? Because according to the WHO, it is the most common cancer affecting women around the world, impacting about 2 million women each year, and also causes the greatest number of cancer-related deaths among women. In 2018, it is estimated that approximately 600,000 women died from breast cancer. That is nearly 15% of all cancer deaths among women. While breast cancer rates are higher among women in more developed regions, rates are increasing in nearly every region globally. However, even though breast cancer has a higher incidence in developed countries than in developing ones, the cancer mortality rate seems to be much higher in developing countries. This is mainly due to delay in diagnosis and treatment. Early diagnosis is a major challenge in breast cancer. Not only breast cancer actually, but in oncology in general, as it is associated with a higher chance of improving outcomes and reducing mortality. If breast cancer is diagnosed early, it is less likely to have microscopic metastasis, and therefore curative surgery is more likely to be done. Screening tests have been available in many countries to improve early diagnosis. Unfortunately, in Syria, cancer care is offered only in the major cities, and most of the breast cancer patients still present with an advanced disease despite the screening programs, which worsens the prognosis and leads to an advanced stage at presentation. In Syria, there were no studies about the efficacy of the screening tests regarding detecting breast cancer. This is what encouraged us to conduct a cross-sectional study in Al Bayruni Hospital, which is an oncology hospital affiliated with Damascus University. This study is the first one to investigate the relations between socio-demographic factors and the practice of breast self-examination, BSE, in breast cancer patients in Syria. The goal of our study is to determine what factors might contribute to performing breast self-examination by these patients and what implications could it have on the stage of the disease. We focused on the demographics of the patients and their characteristics, and we aimed to detect possible barriers that hinder women from performing screening in Syria, to measure the delay in breast cancer diagnosis, to identify its reasons, and to clarify its relationship with prognosis as a crucial key to develop strategies to shorten such delay. Also, to assess the quality of life of Syrian patients and identify its impact on breast cancer patients. Our sample consisted of 532 patients who came from all the Syrian governorates to be treated in Al Bayruni Hospital in Damascus and who were diagnosed between 2005 and 2019. They answered a two-part survey. The first one included each of the demographic information, the patient history, their awareness, and their delay classification, while the second part was a quality of life questionnaire named QOL questionnaire for cancer patients treated with anti-cancer drugs. QOL ACD is a Japanese questionnaire that is used to detect changes in quality of life over time. 22 items were included and were distributed into 5 main categories: daily activities, the physical conditions, the psychological conditions, and the social attitude, and the final one was the facial scale. The QOL ACD questionnaire was translated into Arabic and validated by us. The participants were briefed about the aims of the study and assured that all the phases of the study will be conducted anonymously from data collection to publication. Patients who agreed to participate were interviewed on the spot, and the two-part survey was filled out by 5 sixth-year medical students at Damascus University. Diagnostic, stage, and prognosis were taken from the records. By taking a look at the demographic information of our sample, we can find that the 3/4 of the patients were married, nearly half of them are coming from outside the major cities, 3/4 were living in a private house with their children, and about 2/3 have 3 children or more. 3/4 were doing domestic work, and 2/3 were housewives. Screening methods. Our study shows that the residence location of the patient, whether in urban or rural areas, is significantly related to the performance of BSE. Only about 1/5 of the patients residing in rural areas perform BSE compared to approximately just above a quarter of those who live in urban areas. This difference could be due to the lack of knowledge and education that prevails in rural areas. We have also found that those who are coming from the major cities know more about the symptoms and the most prevalent age of the disease. On the other hand, the education of the patient is also significantly correlated with the performance of usual screening tests. In other words, patients who have primary education or were illiterate had the lowest percentages of doing usual screening tests, while university-educated patients have the highest percentage of performing usual screening tests. It was also shown that the education of the patient is also significantly correlated with knowing the symptoms and the most prevalent age of the disease. The higher the education, the more the knowledge about the disease. In addition to that, from the data analysis, we can find that those who have familial malignancies are more likely to perform usual screening tests and to know more about the symptoms and the most prevalent age of the breast cancer. Moreover, our data analysis shows that each of the number of children a patient has and the type of her work are statistically correlated with doing screening tests and knowing more about symptoms and the most prevalent age of the breast cancer. Patients who had less than 3 children and patients who were not housewives were more likely to perform usual screening tests and knowing more about symptoms and the most prevalent age of the disease. Regarding the delays, the study showed that the delays ranged from less than a month to more than 7 years, but about 64% of the patients took them less than 1 month from seeing the symptoms to the presentation. There was a statistical significance connection when testing having a delay against having fears. For example, 87% of those who had a fear of diagnosis had a delay, and when delay was more than 1 month, it was harder for providing healthcare in more than the half of the cases. Moreover, about 60% of those who thought their case is normal experienced a delay in comparison with only about 30% who did not normalize their case. Continuing with the data analysis, the results showed that after excluding the missing values, patients who came from outside the major cities showed more advancement than those who came from the major ones. And being a housewife is also statistically significantly connected with the advancement of the disease. In addition to that, having a delay for more than a month is also statistically significantly connected with the advancement of the disease. And it seems that having knowledge about the symptoms of the disease or the prevalent age of the breast cancer or even performing the usual screening tests are not statistically significantly correlated. However, when examining the relationship between the year of diagnosis and the advancement of the breast cancer, it has been found that the Syrian crisis years from 2011 to 2017, from 2011 to 2017 had the highest rate of having an advanced stage breast cancer with a percentage of 61.4% in comparison with the duration before the crisis or after the crisis. Concerning the prognosis, concerning the cancer status after 6 months regarding the governorate where the patient comes from, 43.6% of the patients who come from the major cities and 63.6% who come from outside of them showed a response after 6 months to the therapy. Let's move to discuss the quality of life indicators. Patients who were treated with anti-cancer drugs answered the questionnaire to evaluate their quality of life as what I mentioned before. From the results, we can see that the governorate of the patients did not affect the quality of life of the patient, while results show us that the quality of life is affected by the education of the patient. The higher the education, the better the quality of life, in addition to the effect of the economical status. The higher the economical status, the better the quality of life. The stage of the disease and the prognosis after 6 months therapy show an effect on the quality of life too. Finally, from our results, we can see that breast cancer patients who do not live in the 5 most major governorates had higher rates of inaccessibility to healthcare, and this was exaggerated by war. This affected the chain starting from making use of screening methods, delay of management, causing higher rates of advanced breast cancer and a more severe prognosis. Thank you for your listening and for this conference.
Thank you, Masa. Really very interesting research. And as you've said, it's really understudied and under-researched, so it's really important.
Hello, everyone. Thank you all for joining today. My name is Amani Al-Uraibi. I am a pharmacist from Jordan, and I have recently completed my master's degree in global health from the University of Nottingham, where I am currently working as a researcher. And I am very happy to be presenting my dissertation project, which was a systematic review and meta-analysis of the prevalence of non-communicable diseases among Syrian refugees in Syria's neighboring host countries. And I would like to take this opportunity to thank my supervisors, Dr. Laura and Dr. Koshek, for their help and support while working on this research project. This is the outline for what I will be talking about today, and I will start with some background information and why I have worked on this research in particular. To start with, the WHO states that the world's #1 cause of death is non-communicable diseases, accounting for 71% of all annual deaths in 2016, up from 63% in 2013. This indicates that the burden is growing rapidly and has become a real threat that is expected to rise faster in low and middle income countries where most refugees reside. Refugees are particularly vulnerable to NCDs due to migrant-specific factors, which begin in their country of origin and during their migration and upon arriving in the host country, including the lack of legal status, as well as cultural differences, which all play a key role in the poor control of their NCDs. As of August 2020, more than 5.5 million people were registered as Syrian refugees worldwide. Among those, 65%, 15.8%, and 11.9% were hosted by Syria's neighboring countries, Turkey, Lebanon, and Jordan, respectively, while 7.3% were hosted by other countries, which makes these 3 countries host the highest percentages of Syrian refugees, justifying my choice of the selected countries in this review. Syrian refugees are increasing the health burden on Syria's neighboring host countries. The majority of NCDs are preventable, and much can be done to reverse the impact of the public health emergency associated with the Syrian refugee crisis. However, to the best of my knowledge, there has been no previous comprehensive and systematic synthesis of data on the prevalence of NCDs among Syrian refugees. Therefore, we aim to synthesize evidence on the prevalence of NCDs among Syrian refugees residing in neighboring host countries. Now let's talk about the methods that we used. First, the review was carried out in line with the PRISMA guidelines and was registered with Prospero. As for the eligibility criteria, the review included all peer-reviewed studies that reported prevalence data in which the outcome included at least one of the 5 most common NCDs in the target population, that is adult Syrian refugees living in Turkey, Lebanon, or Jordan. The conditions included hypertension, type 2 diabetes mellitus, cardiovascular diseases, chronic respiratory diseases that included both COPD and asthma, as well as arthritis. To cover both the community settings and the clinical field, studies that were conducted in refugee camps as well as outside refugee camps, studies that were conducted in primary care, secondary care, and tertiary care settings were also included, including hospitals and emergency care departments. For the data sources, Medline, CINAHL, Embase, and PubMed were searched from the beginning of the Syrian conflict, which began in 2011, up until 25th of June 2020. The Johannesburg Institute Critical Appraisal Checklist for studies reporting prevalence data was used to assess the methodological quality of individual studies. A data extraction form was created and piloted using Microsoft Office Excel to extract data for each eligible study with a separate column with the number of cases for each type of included NCD. As for the data synthesis and analysis, studies that met the inclusion criteria were categorized into studies conducted in community settings, studies conducted in primary care clinics, and studies conducted in tertiary care settings. Studies that reported on the prevalence of NCDs in community or primary care settings with sufficient data were included in the meta-analysis because we believe that these 2 settings actually reflect the prevalence in the general population. And where meta-analysis was deemed inappropriate, a narrative synthesis was conducted with a descriptive summary and data tables were presented. Heterogeneity was assessed visually and statistically through the use of the I-squared statistic. Moving on to the results, this figure summarizes the study selection process for the evidence used in this review using the PRISMA flowchart. And as a brief summary, of the 262 that were initially identified from the databases searches that I mentioned earlier, 16 studies met the inclusion criteria and were included in this review. Of the 16, 10 were included in the meta-analysis, and the remaining 6 were included in the narrative synthesis. As for the characteristics of the included studies, these tables show further details in terms of the study's design, number of participants from each host country, and how many studies were conducted in each setting, and a total of approximately 236,000 Syrian refugees were actually included in this review. This figure illustrates the prevalence of NCDs among Syrian refugees in community and primary care settings of Syria's neighboring host countries. And overall, as you can see in this figure, the highest prevalent NCD among Syrian refugees living in community settings was hypertension with 22%, followed by type 2 diabetes mellitus with 8%, arthritis 7%, cardiovascular diseases with 5%, and finally chronic respiratory diseases with 4%. the prevalence of hypertension and type 2 diabetes mellitus was much higher in primary care settings, with 35% and 48% respectively. This table further details the pooled estimates of the 5 most common NCDs among the target population, with 95% confidence intervals. Overall, 7 forest plots were created from the meta-analysis, showing point estimates with 95% confidence intervals. However, because of the time limitations, I am only sharing forest plots for the 2 highest prevalent NCDs, that is hypertension in this forest plot and type 2 diabetes mellitus in this forest plot that is showing on the screen right now. Now, let's discuss this review's main points of note, strengths and limitations, as well as implications for future research and practice. It is important to note that the prevalence of hypertension and type 2 diabetes mellitus was much higher in primary care settings than in community settings. And actually, this result was expected because primary care facilities would have a higher population of participants who suffer from a health condition in general and NCDs in particular. Another point of note is that the meta-analysis reported a high prevalence of the 5 most common NCDs among Syrian refugees residing in community settings in Turkey, Lebanon, and Jordan. And our findings were consistent with what was previously reported in 3 national surveys that were conducted by the UNHCR, who also found that hypertension was the highest reported NCD among adult Syrian refugees, followed by type 2 diabetes mellitus. However, there were slight differences in the order of NCDs in relation to their prevalence compared to other literature. And this can be explained by the healthcare system of each host country and the sample size included in these studies. In addition, this review combined data from 3 different countries, while the surveys I mentioned earlier collected primary data from each country separately. One of the key strengths of this review that it is the first systematic review and meta-analysis of the literature, to the best of my knowledge, which has looked at the prevalence of NCDs among Syrian refugees in Syria's neighboring host countries. Another strength of this systematic review and meta-analysis lies in the use of the robust methods. This includes registering the review protocol with the Prospero, which provides a permanent public record of the study aims and objectives, as well as the use of standard guidelines such as PRISMA, which were followed at every stage of the review to enhance the transparency of the review. However, some limitations need to be considered, and these limitations present the opportunity for areas of further research and investigations. And the most compelling limitation is the lack of published data, which limited a subgroup analysis per host country. Nevertheless, this can be argued that the limited available literature is actually due to the period of the conflict in Syria, which started in 2011, that is actually less than 10 years. And there were no clear differences in the NCDs across neighboring host countries in the meta-analysis that we conducted, which shows findings for each country that was carried out. Another limitation was that the overall heterogeneity, as measured by the I-squared statistics, was high. It was actually above 85%. However, evidence suggests that epidemiological data on migrants tend to be heterogeneous. That is why it did not hinder us from doing a meta-analysis. So you must all be wondering, what can this review add? Well, it is an important addition to the current knowledge on the prevalence of NCDs among Syrian refugees. and it provides a further evidence to guide policymakers and healthcare workers who deal with this patient group. Furthermore, the findings of this review should provide a better understanding of the current overwhelming of NCDs, aiding in prioritization for equitable policy and change and preventative interventions for NCDs. In addition, the findings are anticipated to influence other health determinants, such as improvements in individuals' habits to reduce NCD risk factors. To conclude, the findings demonstrate a high prevalence of NCDs among Syrian refugees, and the prioritization of preventative and management interventions for NCDs and future research involving Syrian refugees and host communities are vital and needed to enhance NCD care and tackle these diseases. And from my own experience of working with Syrian refugees, particularly those who had an NCD, I advocate on improving the quality of care and the healthcare services provided to Syrian refugees, as I do believe that opportunities exist for humanitarian and host country actors to provide more comprehensive NCD services to help achieve the global action plan of the prevention and control of non-communicable diseases. It also will help the 2030 Agenda for Sustainable Development Goals that committed to leaving no one behind. Now, I would like to thank you all for listening, and I hope you all enjoy the rest of the conference, and I will be welcoming your questions.
Very much, and good morning, everyone, and thank you for the opportunity for presenting today. Just thank you also, Amania, for the presentation. I couldn't agree more. I think the opportunity for looking at NCDs in emergency humanitarian settings and conflict and post-conflict settings is something that is underappreciated, and I think it's really great that you have a session dedicated to this here. Today I'll be presenting on exploratory research that was undertaken as part of the From the Field project, which is now feeding into a larger GCRF-funded Syrian Food Futures program of research that we're undertaking at the University of Edinburgh with colleagues across the world, multidisciplinary background. I mentioned Lisa, Shahar and Clara here, but we have a much wider team, all of whom have fed into what I'll be presenting today, and I'll be able to show you the full list of the team towards the end. So here I'll be looking at food security and mental health under the COVID-19 syndemic. The presentation outline at the beginning, I look at by way of background, some issues around mental health and food security for displaced Syrians. I'll give you more details on specifics around the project that we undertook and some of the findings that we have found. And then by way of exploring the nature of the project, we have some ideas about how future directions for the research might take. And I think we would benefit enormously from the input from fellow researchers here to think through some of these issues, both conceptual and methodological. I think we faced a number of challenges in undertaking the research. They've delivered us with really interesting findings, but also it would be really useful to see how different researchers have tackled some of these questions and how they're thinking about them also. So just by way of background, looking at the effects of conflict displacement, I think most of us here will be aware that there are significant impacts both in terms of mental health and food security. So on the left-hand side, you can see, as per the Tai and Silova DAP model, some of the aspects of mental health that are affected from people who are displaced during conflict include family separation, exposure to traumatic events, cultural differences that might be faced outside of a home country and when going into a host country, and even failure to have access to justice when post-conflict. Then in terms of food security, of course, conflict displacement also affects Market access, there may be stigma with relation to the individual who's been displaced accessing markets physically, but then also lower family income and institutional breakdown as a result of conflict. Both of these sets of factors, along with many others, contribute to the daily stressors that individuals and families face as a result of conflict displacement. Looking at some of the regional trends in terms of food security, between 1990 and 2017, looking at the global burden of disease data, we can see on the one hand there was a significant reduction in the number of, in the rate of disability adjusted life years for nutritional deficiencies. But at the same time, in terms of non-communicable diseases related to diet, we can see that type 2 diabetes, for example, has been on the increase across countries in the region. And specifically here, I'm showing countries that we have been focusing on as part of our work. I think this is interesting also in terms of when we discuss mental health issues, because obviously diet and mental health are intertwined, as I will discuss a little bit further later. But to look at the profiles of these regional trends should feed into our understanding of what might be going on with relation to mental health and psychosocial well-being. Meanwhile, however, more recently, what we're seeing inside Syria, for example, is that food insecurity has been increasing dramatically. And we have an unprecedented situation now where we have, according to the WFP, 9.3 million who are food insecure. This is an increase from 2019, where it was already a very high 7.9 million. Also worryingly, as you'll see in the graph on the left-hand side, is that the proportion of those who are severely food insecure is also increasing. This has in part resulted in an acknowledgement this year that the SDG 2 on hunger is under threat within the region, and that also projections for regional undernourishment may potentially almost double by 2030. At the same time, looking again at the global burden of disease data, we can see that depressive disorders and anxiety disorders, presentations of those are increasing also again in the countries in the region that we have been looking at as part of our work. I think it's quite notable that depressive disorders and anxiety disorders are themselves in part related to dietary intake on a number of different levels. This won't be the only factor involved, but obviously there is in the literature an impact. So as part of our work in the From the Field project, we looked at how we may take the Sustainable Development Goals 2 and 3 with relation to hunger and health, and how we may think about these in the context of Syrian displacement. So our From the Field project, it was a multidisciplinary global research collaboration exploring COVID-19's impact on the lives and livelihoods of Syrians. And as I'll discuss later, how we think through the effect of COVID-19 on the already pre-existing trends around food insecurity and mental health issues is quite challenging, but also an important pathway of research that we think needs to be further explored. In particular, we had been looking at Lebanon, Iraqi Kurdistan, Jordan, Syria, and Turkey. We deployed remotely as a result of the nature of the COVID-19, 100 cross-sectorial questionnaires between April and June 2020. In addition to these questionnaire surveys, we requested from participants with their consent video ethnographic data. So essentially individuals involved would submit to us how they envisage their engagement with food in their daily lives, and I'll come to that in a second. So just in terms of a profile of the sample, the 100 participants, as you can see, pre and post displacement, were displaced either within Syria or into neighboring countries included in our profile. The average age was about 36. We have some limitations in terms of the representativeness of the sample. 25%, so 25 women were included in the sample, and it was a convenient sampling. So we are aware of the limitations around representative claims with the data that we have. In terms of food security, we use the Food Security Coping Strategies Index, which is utilized within humanitarian sectors. That provides us a profile in terms of the kind of coping strategies that families may be using. So for those that are not familiar with the measure, this includes relying on less expensive food, buying food on credit, limiting portions, going days without eating, for example. And here we can see, just by looking at the graph, already less expensive food and limiting portions of food were significant coping strategies for the profile that we were investigating. In terms of the mental health sample, then, we were using the Short Warwick Edinburgh Mental Wellbeing Scale, which is a positively worded mental health scale. It isn't typically used for diagnostic purposes, so that means it's not typically used in order to diagnose someone with a particular condition. However, there is a threshold within the data that's validated to show that scores underneath 20 are typically of mental health concern. And as you can see here, about 20%, a fifth of our sample gave responses to the questions which indicated that they were consistent with symptoms of depression and/or anxiety. When we looked at the quantitative responses, we saw that there was an association between food security and mental health. So here we can see that there was a small to moderate correlation between mental health and food security. And that's consistent with most of the literature, which shows that there is indeed those that show greater levels of food insecurity also demonstrate lower levels of mental psychological well-being. Also, when we looked a bit closer at the data, we also saw that greater food insecurity was correlated with lower meal frequency and reduced food intake through the questions that were asked. In addition, as I mentioned earlier, we had engaged the sample in requesting some submission of videos and different sorts of visual multimedia representations of how they engage with food in their lives. And two of my colleagues, along with our data collectors, so Anne and Mackenzie, have looked in detail at how this visual material and this qualitative data represents their engagement with food in their day-to-day lives. And I think it was quite apparent to us that the responses that people provided showed that there was a rich, thick engagement with food in a variety of different sectors of their lives. So just some images here show that it engages with livelihoods, it affects children, their education. It's engaging in agriculture and working with the land. It's engaging with local markets, and it really shows the multi-dimensional role of food. And I think as part of this research, it showed to us that the extent to which food security as a concept and engaging with that, limitations that might be imposed with our current understanding may limit how we think these links exist with, for example, mental health. So it is in that context that we have been exploring and looking at the call of the Food and Agricultural Organization's higher level expert panel on introducing an additional set of concepts to their understanding of food security. So the typical understanding of food security that's utilized by many NGOs and humanitarian organizations is with relation to access, availability, stability, and utilization. Now, the expert panel is calling for the addition of agency and sustainability. And just to focus on this additional criteria of agency, the idea is that building on a lot of the conceptual work that was outlined by Amartya Sen, is to see how a person is free to do and achieve in pursuit of whatever goals and values he or she regards as important. And I think what's important to recognize here that by introducing agency as a criteria within food security, we're now in a much deeper way acknowledging the way in which people engage with food in their everyday lives. And I think potentially the restrictions around food security as a concept may have limited the ways in which it has been linked with other aspects of their mental health and psychosocial well-being. The second reflection that we've had in terms of the research, the exploratory research we've undertaken, and again, it would be good to hear from colleagues here about this, is how the concept of the syndemic has been deployed to help capture the complexity of COVID-19. So for those that may not be aware of the concept, how it is understood that COVID-19, like other virus outbreaks, is not necessarily a simple pandemic, but rather that the biological consequences of this particular virus outbreak may interact with other illnesses and diseases, including NCDs, and also social interactions with social factors. And this has been outlined by Horton recently in the Lancet, arguing that by seeing COVID-19 simply as a pandemic, we may be missing a lot of the factors that are actually affecting people's health and well-being. In this context, then, what we've been trying to do is to conceptualize how COVID-19, mental health, and food security may interact. And I think what we outline here in the diagram is an effort to try and conceptualize this. So, as outlined earlier, food security and mental health are already in a significant relationship with regard to maintaining people's general health and well-being. So, mental health deterioration also has an impact on food security, and a food security deterioration has an impact on mental health. That seems to be quite well established in the literature. But what we see with COVID-19 is that it's having an impact both in terms of mental health. So, for example, the virus itself is having an impact on people's, mental health, cutting off social contacts, anxiety about the virus, on the virus, but also that COVID-19 is impacting on food security by compromising access to markets, by making people less comfortable with engaging with others, and a variety of different nutritional impacts that are affected in food security deterioration. This in turn then has the consequence of depleting or undermining immune system defenses. So individuals whose mental health and food security is lowered are also more at risk of contracting or experiencing very significant effects from the virus. So then, maybe to conclude, some thoughts for future research and practice. We do believe that an epidemiological understanding is improved by appreciating the current situation as a syndemic, and that this allows us then to engage with the various different links COVID-19 has with a variety of different NCDs like mental health and mental health issues, but also with relation to social issues like food security that affects many displaced Syrians. We think there's an imperative for Syrian-led research on the role of agency in food security and mental health interactions during COVID-19, precisely because we need to understand better how individual Syrians are maybe expressing idioms of distress with engagement to their food security situation, but also to understand local patterns of engaging around food issues locally. And we believe that our research findings should inform diagnostic practices and humanitarian interventions. So essentially, again, to understand better how food security links with mental health under COVID-19, potentially food security could be a feature of people's inability to, the diagnostic practices may be improved as a result of understanding better how their food practices change as a result of various different mental health issues. Also, humanitarian interventions may be improved by deploying multi-level and multi-sectorial interventions. So in tackling COVID-19 and our food security, we should also be looking at how these same interventions, these programmatic interventions, allow for tackling various different factors. One such example of this is what's called Cash Plus, and there has been a randomized controlled trial in Lebanon which has showed positive results by trying to tackle food security and mental health issues simultaneously. Unconditional cash has the benefits of allowing people to meet their food needs. At the same time, by linking that with MHPSS, mental health and psychosocial support interventions, it also allows us to link people up with support services in their community. So finally, as mentioned, we have quite a significant large team, many of whom obviously can't be with us today, but they are widespread team based in Edinburgh and Syria and the region. So the work that's presented here today is in large thanks to them. Please, as I mentioned, we are looking for ideas if there and collaborations with different organizations. If there are any thoughts or questions, please do contact us, and our details are there. So thank you very much.
Thank you, Joseph. Really, really very impressive work. And yeah, and I'm really pleased that I have seen this multidisciplinary, multi-sectoral work that's been conducted into the Syrian context, because I believe that we lack this mindset of just collaborating together with different backgrounds, different scientific languages, and just try to do something together. I'm trying to see if any of the participants have questions to Joseph, unless I can start with mine. So if you do have any questions, please either jump in and just let us know, or just write it down in the chat part. So I do have two questions, and maybe then we can just go to the other presentations. The first one is that from me understanding the cultural background of Syrian people, I know that it's really very tricky for them to talk about poverty or food security, or stuff like those vulnerabilities. So how you have addressed this? And I can see from the team that there are lots of people who might already know this, and I'm sure that you were aware of the positionality of you as researchers, and how this is a very sensitive topic to talk about, and how you make sure that they are just open to discuss those things with you. The other question is related to COVID and social inequalities, because I believe that any like huge global pandemics is just like affecting the more vulnerable, the poorest. And when talking about displaced people in Syria, inside Syria or outside Syria, we need to acknowledge the fact that they do have limited job security. So this is a huge thing that we need to focus on, because with them just working casual works, and with the new rules of not going to work, they might lose their income from the first place. So how is that was mentioned in the from the participants, I mean?
Yeah, I mean, two super questions, and I wish I had another half an hour to touch upon them. The whole presentation really could have been on the cultural response, the cultural responses around mental health. I think that was one of the biggest challenges. I should emphasize, wanted to underline within the presentation, that the data collectors that we had were either Syrian and or local individuals. So in Lebanon, Iraq, Syria itself. So the data collectors themselves were either trained or had a personal knowledge around cultural factors that might affect the respondents. Having said that, even with that knowledge and that local experience, understanding that it's very difficult for people to communicate. It's very difficult for people to communicate their feelings of distress, and how they do that was a fundamental part of the responses. And one of the key things we were looking at was how were people responding within the formal parameters of the survey vis-a-vis when they were speaking with the data collector outside of those formal questions. Because actually what people took was this is an opportunity to express what was going on in their lives. So they may be asked a question that had a scale, and they may be asked to respond, 1 to 5, how much they were being affected in a certain way. But then they often continue to speak after that. And that also shows the importance of having that semi-structured qualitative response. With regard to the second point, this is only one element of the entire From the Field project. So I wasn't able to present today. Many colleagues were working on a variety of different issues around livelihoods, access to water, sanitary products, and so on. It's really one element of it. So part of the questions that were asked also detailed their situation around employment and other issues. And I think that's also something that we would want to explore further. I think how the two were linked in terms of their concerns about their economic situation was definitely featuring as part of the wider responses about how they were, what their emotional state was in responding to the survey.